Sir, good afternoon.
Good afternoon. Good afternoon.
Sir, you can start.
Okay, thank you. Thank you.
Okay.
So, good afternoon, all. This is Dr. Mayank Gupta, works as Associate Professor in Department of Medicine, NIMS Medical College. So, today's topic is very interesting, yet day-to-day complication. We all physicians, I must be sure that you all people will be encountering with this problem, diabetic ketoacidosis. We have diabetic patients with us, type 1 diabetics, type 2 diabetics, and this ferocious complications, though it is very easy to understand and taken care of, but still most of the people found it very difficult to manage diabetic ketoacidosis. So I'm trying to make it very simple with easy examples so that we can basically understand what is DKA, how can we manage the ferocious complications of diabetic people. So with this onset, I'm starting my presentation on diabetic ketoacidosis. So see, as you all know, what are the learning outcomes from today's class? So improved understanding of fluid resuscitation, which is the most important part in the DKA management protocols for different patient populations like adult people, pediatric patients, pregnant patients who are having diabetes and presented to us with DKA. Skill development in managing complex electrolyte disturbances, especially potassium. When we are managing DKA, the most important complications is either hypo or hyperkalemia. Enhanced ability to make decisions regarding insulin therapy and fluid adjustments based on the clinical context of that particular patients. So yes, three pillars: fluid resuscitation, insulin management, and controlling or managing electrolyte imbalance. Recognition of complications and timely escalation of high-risk patients is very important to understand. Not each and every patient is the same. So if he or she is high risk, be it pregnancy, be it pediatric age group, be it comorbidity, so you have to manage DK very cautiously. Case-based approach allows to engage in critical thinking, build clinical decision-making skills, and understand how to adapt fluid management strategies in various clinical scenarios. Now, introduction to DK, as you all know, it is the leading cause of morbidity and mortality in children with type 1 diabetics. DKA usually occurs at the time of diagnosis in case of type 1 diabetes, around 30% of the children, and in type 2 diabetics, 5 to 25% of young diabetics. It occurs in type 2 diabetes under conditions of extreme stress and less often as its presenting manifestation, a disorder which is called as ketosis-prone diabetes mellitus. So, definition of DKA as per ADA and ISPAT, presence of all of the following in a patient with diabetes. Number one, we are talking about diabetes. So, hyperglycemia, blood glucose more than 200 milligram per deciliter in case of children, and in adults, if it is more than 250 milligram per deciliter. Metabolic acidosis, if venous pH is less than 7.3 or serum bicarb is less than 15, but in adults, it is less than 18 milliequivalent per liter. And ketosis, that is presence of ketones in the blood, that is more than 3 millimole per liter beta hydroxybutyrate, which is the most common ketones, or urine, that is moderate to large amount of urine ketone. So you have to remind three things, or you have to remember three things: increased blood glucose, presence of acidosis, and presence of ketosis. Now, this is the basic pathophysiology of diabetic ketoacidosis. You must all be aware about this. Simple in case of type 1 diabetes, that is absolute insulin deficiency or precipitating factors like stress, infection, or if there is insufficient insulin. In those cases, resurfaces counter-regulatory hormones like glucagon, catecholamines, growth hormone, and cortisol, which leads to most important point, that is lipolysis, decreased glucose utilization, increased proteolysis, and increased glycogenolysis. These all leads to hyperglycemia and sorry, due to lipolysis, increased free fatty acid delivery to liver leads to ketogenesis, and increased acidosis leads to increased lactate level. These both increased lactate level, hyperglycemia leads to osmotic diuresis, loss of water and electrolytes, and leads to further dehydration. And due to patient is having DKA, decreased fluid intake leads to hyperosmolality and impaired renal function. So this is the basic pathophysiology of DKA. Now, what can be the etiology? Inadequate insulin treatment or non-compliance, which is the most important problem in our country, in our scenario, which is very important to make our patient compliant about insulin. New onset diabetes in case of 20 to 25% as a presenting complication. Acute illnesses like infection, CVA, MIs, acute pancreatitis, and drugs like clozapine or olanzapine, cocaine, lithium, SGLT2 inhibitors, or terbutaline. Most important complication in current scenario, those patients who are using insulin pump. So pump malfunction, number one, other endocrinal disorders like thyroid toxicosis and use of steroids. Now, what are the clinical manifestation of DKA? As we all know, extreme thirst, headache, frequent urination, nausea, vomiting, feeling very tired or weak, pain abdomen, fruity smell. That is very important point to understand or to delineate DKA at OPD or emergency setting. Rapid deep breathing, presenting with confusion, drowsiness, progressive obtundation, and loss of consciousness. Now, what are the markers of severity in DKA? It's very important. Presence or absence of DKA is another thing. After diagnosing a DKA, whether he or she is severe or not, what are the parameters? Blood ketones level that is more than 6 millimole per liter, bicarbs less than 5, venous or arterial pH below 7, presence of hypokalemia at the time of admission that is less than 3.5, GCS less than 12 or abnormal ABPU scale, saturation less than 92% on room air, BP systolic less than 90, that is patient is in hypotension, tachypnea, tachycardia, pulse more than 100 or less than 60, or anion gap is very important to evaluate anion gap. Anion gap if it is more than 16. Now, severity is categorized on the basis of acidosis, that is mild, moderate, severe. If pH is less than 7.3, less than 7.2, less than 7.1. Respectively categorized in mild, moderate, severe DKA, or serum bicarbs less than 15 or less than 7 or less than 5 respectively. Now, as we all know, fluid and electrolyte imbalance is the most ferocious complication in DKA which we have to manage. So how do we assess volume status clinically? Capillary refill time, old age practice, if it is normal, that is less than equal to 1.5 to 2 seconds. Abnormal skin turgor, that is inelastic skin due to dehydration, which is useful for predicting around 5% of dehydration. Others like dry mucous membrane, sunken eyes, absent ears, or cool extremities. But for more than 10% dehydration, that is moderate to severe dehydration, there must be a weak thready pulse, patient is in hypotension, and there is very reduced urine output, that is oligouria. So what are the issues related with volume status? Measured weight loss. You have to understand best estimate of volume depletion if an accurate recent measured weight is available for comparison. Like 2-3 days back, a patient is having his or her weight of say 70 kgs. But during ICU admission or in emergency setting currently, presenting with DKA, his or her weight is 64. So this is the measured weight loss, that is 6 kgs. So this is the best estimate. Now, what is the target for fluid depletion? It relies on assumptions of a 5 to 10% fluid deficit. Always remember this term, 5 to 10% of fluid deficit, rather than on clinical estimates of dehydration. Don't rely on clinical estimates, but always clinically evaluate the patient and then always remember this term, that is 5 to 10% fluid deficit. Now, individuals with DKA, they are hypovolemic at presentation, obviously, and hence associated orthostatic hypotension is common. Individuals with hypertension, they are more likely to have severe DKA or alterations in mental status, which are established risk factors for DKA-related cerebral injury, that is cerebral edema. Now, what are the goals of therapy in DKA management? Obviously, we have to correct acidosis and reverse ketosis. We have to correct dehydration, restores blood glucose to near normal, monitor for complications of DKA and its treatment. Yes, identify and treat any precipitating factor, because if you are not treating any infections, MI, CV, or any precipitating factor, we cannot control the complications of DKA. Now, what are the metabolic treatment targets? You have to memorize it. Reduction of the ketones level concentration by 0.5 millimole per liter per hour. Very important, per hour. Increase the bicarbs level by 3 millimole per liter per hour. Reduce capillary blood glucose by 3 millimole per liter, that is per hour, that is 54 milligram per deciliter. Maintain potassiums between 4 to 5.5. So remember these 4 terms: reduction of blood ketones by 0.5, increase bicarb level by 3 millimole, reduce the blood glucose by 3 millimole, that is around 54, and maintain potassium levels between 4 to 5.5. Now, what are the main stem of DKA management? Fluid therapy, potassium replacements, insulin therapy, and if there is complication, management of cerebral edema. Now, number one, fluid replacement is very, very easy, but yet very important to understand how we are improving the hydration status of our patient. So clinical signs of dehydration tends to be inaccurate, as we have already highlighted, for assessing dehydration. Hence, in moderate DKA, always assume 5 to 7%, and in severe, it is between 7 to 10% of dehydration. Usual fluid deficit in children is 70 ml per kilogram, but in adults, it is 100 ml per kilogram, usually with moderate to severe DKA. And the current weight should be used for calculations and not the weight from a previous office visit. This is very, very important, as I had already mentioned and highlighted. Current weight is important, not on the last OPD visit. Now, what are the main objectives of fluid therapy? Restoration of circulating volume, most important. Replacement of electrolytes. Improvement of urine output by improving eGFR and clearance of glucose and ketones from the blood to restore osmosis. What is the choice of fluid? In most of the cases, it is NS 0.9%. But if corrected sodium is more than 150 milliequivalent per liter, then use N by 2 or 2/3 or 3/4 according to the degree of hypernatremia. It's very important to calculate corrected sodium in each and every patient of DKA after doing ABG. Now, when we are replenishing fluid, there are two phases. Initial phase, aggressive phase, that is volume expansion phase, and then rehydration phase. So in volume expansion phase, you have to act within 1 to 2 hours or till patient's vitals are stable. That is, you have to infuse 15 to 20 ml per kilogram per hour. In case of rehydration phase, duration is 2 to 48 hours. You have to infuse fluid at the rate of 4 to 14 ml per kilogram per hour, depending on the state of hydration. See, these are not exact words or these are not exact infusion rates, because in each patient you have to understand his or her volume status and as per the patient's vitals. So you have to monitor vitals, electrolytes, and everything continuously in case of DKA management. So when blood glucose reaches 250 milligram per deciliter, assess the patient's hemodynamic status or hydration status. Now, if your patient is rehydrated enough, mind the word replace. Replace IV fluid to D5 or D10. That means initially we are giving NS, and if patient is rehydrated enough, replace it to D5. But if patient is not rehydrated, add. Here we are not mentioning replace, add D5 to D10 to already infused IV fluids. So 2 points are important. When blood glucose is less than 250, patient's rehydration is achieved, replace the fluid to D5, D10. If it is he or she is not rehydrated, add it is to normal IV fluid. Now, when we are talking about initial volume expansion phase, IV bolus of 10 to 20 ml per kilogram using 0.9% NS. Simple, if a patient is having weight of 70 kilogram, 70 into 20, that is around 1400 ml. So you have to infuse 1400 ml in 2 hours. If circulating volume is still compromised, additional IV bolus of 10 to 20 ml per kilogram can be easily given. But in case of obese patients, to avoid excess fluid administration, fluid calculations, it should be based on an approximation of ideal body weight for height. It's very important. If a patient is of 90-100 kg, BMI of 28 or 30, you have to calculate fluid on the basis of ideal body weight for height for that particular gentleman. Now, when we're talking about maintenance fluids after initial volume expansion, once patient is hemodynamically stable, replace the remaining fluid deficit over 24 to 48 hours using IV fluids, either 0.9% NS or half saline. After the second or third hour, optimal fluid replacement, it depends upon the state of hydration. If your patient is hydrated or not, what is the serum electrolyte level and the urine output. These three are the cornerstone of the DKA management. If your patient is urinating, his or her electrolytes are normal, or what is the state of hydration. So most appropriate IV fluid composition is determined by the sodium concentration corrected for the degree of hyperglycemia. Always mind for corrected sodium concentration, because this is the actual situation which is calibrated by the degree of hyperglycemia. So what is the aim? Aim is to gradually reduce serum effective osmolality to normal, because our aim is not to control numbers, but to reduce serum effective osmolality. Now, when we are talking about type 1 diabetic children, so for calculation of fluid, we are following holiday cigar formula. That is, average water deficit in children is around 70 ml. 24-hour maintenance required as per body weight of the children. If a child is less than equal to 10 kg, you have to give 100 ml per kilogram for 24 hours. If a child weight is 10 to 20 kilograms, so first add 1000 ml with 50 ml per kilogram for 24 hours for each kilogram from 11 to 20. Similarly, when the weight is more than 20, you have to add 1500 ml plus 20 ml per kilogram 24 hours for each increase more than 20 kgs. Most important slide. When we are talking about DKA management, you cannot forget potassium. So in case of potassium replacement, always establish adequate renal function. Urine output should be more than or equal to 50 ml per hour. If a patient is having oliguria, is not urinating, first and most important thing is to give appropriate volume expansion so that his or her urine output should be 50 ml per hour. After that, if serum potassium is less than 3.3, hold your insulin, give 20 to 30 milliequivalent potassium per hour until potassium is more than 3.3, because if you infuse insulin, it will further create hypokalemia. If serum potassium is 3.3 to 5.3, give 20 to 30 milliequivalent of potassium in each liter of IV fluid to keep serum potassium between 4 to 5. But if serum potassium is more than 5.3, do not give potassium, but there is a catch. Check serum potassium every 2 hours. It's very, very important. Do not rely on the single potassium values. Now, the most important and heated discussion in a case of DK management, how to give insulin, which insulin, when, how to escalate, how to de-escalate. So in a very simple point, I am covering simple basic points so that we can easily manage our sugars. So initiate treatment with low dose IV insulin in all patients with moderate to severe DKA who have a serum potassium more than 3.3. So basic requisite, first check potassium levels. Now IV regular insulin and rapid acting insulin analogs, they are equally effective in managing DKA. Start insulin infusion at least 1 hour after starting fluid replacement. Very, very important in our emergency setting. Always guide your residents or MOs posted at the emergencies. Never start insulin before fluid resuscitation. That is after the patient has received initial volume expansion. So first and foremost thing is expand volume, give IV fluids. And IV bolus should not be used. This is very, very important crux of my class. Never use IV bolus insulin at the start of therapy. In old age times, since our MD times in our medical college, we used to give, but this is a crime to give IV insulin. Why? Because it increases the risk of cerebral edema. Number one, it can precipitate shock by rapidly decreasing osmotic pressure. And third, it can exacerbate hypokalemia. So always remember these 3 points. Never give IV shot of insulin because it can increase the risk of cerebral edema. It can precipitate further hypokalemia and can cause shock by rapidly decreasing osmotic pressure. So now, how can you manage DKA sugars? So never give a bolus. Start continuous insulin infusion at the rate of 0.05 to 0.1 kilogram, unit per kilogram per hour, starting 1 hour after fluid initiated. Again and again, I'm highlighting after fluid initiation. If blood glucose is less than equal to 300 milligram per deciliter or blood glucose falls more than equal to 90 milligram per deciliter, so your IV therapy, change it to half, that is 0.45% or 0.9% saline. Continue it. Add glucose containing fluids D5 or D10 to prevent hypoglycemia. Adjust sodium infusion to promote an increase in measured serum or sodium. As I had initially mentioned, we have to reduce wisely osmolality. Now, if a patient is improved clinically well, ketoacidosis is resolved, and he or she is tolerating oral fluids, you can transit it to subcutaneous insulin. But most important point, start subcutaneous insulin, then stop IV insulin after an appropriate interval. Never transit directly from IV to subcutaneous. Always overlap. Hold for some time. Give subcutaneous insulin. If he or she is tolerating well, there is no vomiting, gradually stop your IV infusion. Now, when we are talking about IV route in case of insulin, regular insulin 0.05 to 0.1 units per kilogram as an IV infusion. If serum glucose does not decrease by 50 to 70 milligram per deciliter in first hour, double IV and subcutaneous insulin bolus, because our ultimate aim is to reduce sugar levels. In case of uncomplicated DK, if you are rapidly starting on subcutaneous route, rapid acting insulin, give 0.3 units per kilogram, then reduce it to 0.2 units per kilogram. 1 hour later, check sugars every 2 hours and maintain on 0.2 units per kilogram. So now when serum glucose reaches 200 milligram per deciliter in both the settings, reduce regular insulin infusion to 0.02 to 0.05 units per kilogram per hour. That is half the infusion rate, or give rapid active insulin 0.1 units per kilogram every 2 hours. Main aim is to maintain serum glucose between 150 to 200 until resolution of DKA. That is, proper fluid is given, electrolytes has been controlled, acidosis has been cleared, ketones has been cleared. So maintain 150 to 200 milligram per deciliter. Now, once TKA has resolved and patient is able to eat and drink, subcutaneous insulin therapy can be restarted. It is important that IV insulin infusion is not discontinued until at least 30 to 60 minutes after the administration of subcutaneous insulin. It's very, very important. Always overlap. Never shift directly. Now, this is the most heated, arguable, and discussed point in every DKA meeting: bicarbs. So, in one line, use of bicarbs in DKA always remains controversial and it is explicitly not recommended. This is very, very important. We are not recommending bicarbonates regularly in the management of DKA. So according to ADA guidelines, it can be given in few circumstances. Very, very important to understand and remember: if pH is less than 7, patient is having severe hyperkalemia, and if a patient is comatose, that is in coma. So 100 millimole per liter bicarbs you have to add 100 millimole per liter bicarbs in 400 ml NS with 10 to 20 milliequivalent of Kesol, infused over 2 hours. Repeat every 2 hours till pH is more than 7. So one criteria: pH less than 7, start bicarbs in infusion. When pH raises more than 7, initially stop bicarbs and monitor serum potassium every 2 hours. So bicarbonate should be discontinued when the pH rises above 7. Now, most important and ferocious complication of this complication: diabetics have complication DKA, and complicated DKA has cerebral edema. So how to manage cerebral edema? Start mannitol in the dose of 0.5 to 1 gram per kilogram IV over 10 to 15 minutes. Effect of mannitol comes in usually 15 minutes and is expected to last about 2 hours. If necessary, the dose can be repeated after 30 minutes. Second alternative is hypertonic saline. Suggested dose is 2.5 to 5 ml per kilogram over 10 to 15 minutes. It is used as an alternative to mannitol or in addition to mannitol if there has been no response to mannitol within 15 to 30 minutes. Hypertonic saline 3%, 2.5 ml per kilogram is equivalent to 0.5 gram per kilogram of mannitol. You have to understand and remember, it's very, very important point, that is management of cerebral edema. Now, when you label a patient of DKA resoluted, that is resolution of DKA. So what is the criteria? Number one, blood glucose less than 200 milligram per deciliter, and two of the following criteria: serum bicarb if it is more than equal to 15 milliequivalent per liter, pH more than 7.3, and calculated anion gap should be less than equal to 12. So you have to remember these 4 points. Necessary mandatory points is blood glucose less than 200, and out of 2 points, pH less than pH more than 7.3, bicarbs less than 15, and corrected anion gap less than equal to 12. And the most important point, as a real world evidence, patient is able to eat. This is the most important point. So assessment of urine or serum ketone levels by the nitroprusside stick test should not be used for monitoring the resolution of DKA. Yes, you can monitor ketones by doing nitroprusside method, but you cannot label a patient of DKA resoluted by monitoring this test. Now we are discussing some case-based presentation in DKA management so that you can understand in different situations, like a patient is adult, if a patient is pediatric, a patient is presenting with comorbid, or a pregnant patient, which fluid we have to give, how we can manage potassiums, when or where we have to intervene with the insulin management. So case detail: adult patient, 45-year-old male, type 1 diabetic, presented with vomiting, polyuria, confusion, and fruity based odor. All clinical signs are waving towards DKA. Initial lab results: hyperglycemia 650, pH 7.1, bicarbs 12, sodium 135, potassium hyperkalemia 5.8, anion gap is very high 18, ketones 2+. So now, what are the questions and how can we manage this DKA? So how would you initiate fluid resuscitation in this patient? Very important. Adult type 1 diabetic DKA. So primary goal of fluid resuscitation in DKA is to restore, as we had highlighted, intravascular volume. So which is typically around 5 to 10% of body weight in DKA patients. Initial fluid and administer 1 to 2 liter of isotonic saline as a bolus over 1 hour. This is done to correct hypovolemia due to fluid losses. What is the rate of subsequent infusion after to one initial bolus? You have to continue fluids at 250 to 500 ml per hour to replace fluid deficit. Adjusting the rate, which is very important, you have to adjust the rates depending on ongoing losses, vitals of the patient, and clinical response. Electrolyte monitoring, always keep this thing in mind, the patient's sodium levels and potassium levels, because any dilutional hyponatremia or worsening potassium can destroy the management of DKA. What is your approach to potassium management in this adult diabetic presented with DKA? It must be monitored closely due to shifts caused by acidosis, fluid management, and insulin therapy. In this case, potassium level is 5.8, which is above normal. However, because the acidosis is very severe, the total body potassium might still be depleted due to intracellular shift, which is very important to understand. Now, action. Even though the potassium is slightly elevated, insulin therapy will push potassium back into cells, potentially causing further hypokalemia. So if the potassium level drops below 5, initiate potassium replacement. A common strategy is to add 20 to 30 milliequivalent of potassium chloride per liter of IV fluids to avoid a precipitous drop in potassium. Recheck potassium every 1 to 2 hours to guide further replacement. Now, how will you address the patient's acidosis? We have managed fluid, we have managed potassium. Now, how will you address the patient's acidosis? Always remember, most effective treatment is the administration of insulin when we are talking about correcting acidosis. So it is primarily metabolic, caused by the accumulation of ketones, that is beta hydroxybutyrate and acetate. Insulin reduces ketogenesis and lowers the blood glucose, thereby correcting the acidosis over time. So what is the role of bicarbs? Because in any case of acidosis, we always think of bicarb, but in case of DKA, always think of insulin for managing acidosis. As we had already discussed, it is rarely necessary to use bicarbs unless the pH is less than equal to 7 or less than 6.9 and the patient is severely symptomatic. Example, altered consciousness, hypotension. So in this case, the pH is 7.9, which is not critically low. So rapid correction of acidosis with bicarbonate, it can result in severe complications. You have to remember complications including hypokalemia and a paradoxical worsening of acidosis once the bicarbonate is metabolized. So always remember, if you infuse bicarbonate without use, it can further lead to hypokalemia and further worsening of acidosis once the bicarbonate is metabolized. Second case, a pediatric case, 10-year-old girl with type 1 diabetic, admitted with altered mental status, tachypnea, pain abdomen. Initial lab results, hypoglycemia, pH 7, bicarb very low, 10, sodium 130, potassium 3.2, which is less, that is hypokalemia, anion gap 20, very high, and ketones 3+. Now, how would you calculate and administer fluid resuscitation? Important point, she is a child, 10-year-old child. So the goal is to restore intravascular volume, correct dehydration, avoid overhydration. So recommended in initial fluid bolus is 20 ml per kilogram. For this 10-year-old child weighing 30, so initial bolus is 600 ml. Subsequent fluids after the initial bolus, the patient can receive 1.5 to 2 times the calculated fluid acids. You have to infuse it over 24 to 48 hours with continuous monitoring of vital signs, electrolytes, and urine out. Now, what are the steps will you take to correct the electrolyte imbalance in this pediatric age group? The child's potassium is 3.2. Most important is potassium replacement. So potassium should be replaced if it is less than 5, as hypokalemia can lead to arrhythmias, weakness of the muscles, or respiratory problems. So common strategies to add 20 to 30 milliequivalent of potassium chloride per liter of IV fluids. Once the child is urinating, very important, once the child is urinating, if urine output is insufficient, or the potassium falls below 3, consider adding potassium directly to the IV fluids. Monitor potassium every 2 hours. Sodium correction, be cautious of dilutional hyponatremia, especially if there is high serum glucose. So always use, I had already mentioned, always use corrected sodium equations to assess true sodium levels during the therapy. Now, how should you adjust insulin therapy in a pediatric patients? Pediatric insulin therapy in DKA is usually started with the lower infusion rates to prevent rapid shifts in glucose and electrolytes. Start an IV infusion of regular insulin at 0.05 to 0.1 units per kilogram per hour. In this case, that must be 0.5 to 1 unit per hour. After fluid resuscitation is initiated, monitor the blood glucose to achieve a gradual reduction in glucose. Aim for a decrease in 50 to 75 milligram per deciliter per hour. If the glucose falls too quickly, say less than more than 100 milligram per deciliter, it reduces the insulin infusion rate to prevent complications like cell edema. So you have to be very cautious. Don't reduce or don't lower the glucose levels very rapidly. Dextrose, when blood glucose reaches 200 to 250 milligram per deciliter, switch to a glucose containing IV fluid D5 to prevent hypoglycemia. Now, case 3, very important, very interesting. A patient, pregnant female, 30 years, 28-week gestation, type 1 diabetic, admitted with pain abdomen, polyuria, and dehydration. Lab results: uncontrolled sugars 450, pH 7.2, bicarbs 15, potassium 4, sodium 140, anion gap is high 140, ketones is 3 plus. So this is a classical case of DKA complicated in a pregnant female. Now, what food regime would you initiate in this pregnant patient? Very, very important. Pregnant patients with DKA need careful monitoring, as you all know, to ensure adequate hydration without overloading, especially in the setting of fluid shifts that can affect both maternal and fetal well-being. Because a pregnant female is carrying a fetus, you have to be very careful in resuscitating this female, because this can lead to metabolic dysfunction, fluid overload. So initial fluid bolus, administer 1 to 2 liter of NS as an initial bolus, carefully monitoring for the any sign of fetal distress like abnormal fetal heart rate or uterine contractions. Subsequent fluid therapy after the bolus, continue IV fluid at a slower rate, that is 200 to 500 ml per hour. But it always depends on maternal vital signs and urine output and signs of fetal distress. So how would you manage electrolytes in this patient? Potassium should be monitored very closely. Female patient, pregnant female, potassium is 4. There is a risk of hypoglycemia as insulin has been started. So potassium should be replaced if potassium falls below 3.5. Typically 20 to 30 milliequivalent per liter of potassium is added to the IV fluids. Close monitoring is essential, and potassium replacement should be adjusted based on the laboratory results. So monitor maternal renal function, serum electrolytes, and fetal rate frequently, as we had highlighted this point in fluid resuscitation point also, and correct any abnormalities immediately to prevent any fatal problems for both the mother and children. So should insulin therapy be started differently in this patient due to pregnancy? Very, very important and tricky question. The same general principle you have to follow. Start with a lower insulin infusion rate, that is 0.05 to 1 unit per kilogram per hour, to avoid a too rapid reduction in glucose, which could cause maternal hypoglycemia or fetal complications. Monitoring, frequent glucose monitoring is required with a target reduction in BG of 50 to 75 milligram per deciliter per hour. When blood glucose reaches 200 to 250, switch to a glucose containing IV fluid. Ensure that insulin therapy does not lower the glucose too quickly, as this may compromise the fetus, and monitor for the signs of maternal hypoglycemia. So in a case of pregnant female, you should always remain vigilant and cautious to monitor blood glucose at every hour, because sudden depletion of glucose level can lead to fatal complication for both mother and his child or fetus. Now, very interesting case if a patient presented with the DKA and other comorbidities. So 60-year-old male with type 2 diabetes, history of CKD, admitted with severe DKA. His glucose is 800, pH is 6.9, bicarbs 8, sodium 132, potassium 5.5, very high anion gap, ketones are 4 plus. Now, what do you suspect regarding his electrolyte and fluid status? Mind you, case of diabetic, 60-year with CKD history. So this patient has severe DKA with acidosis, and his renal dysfunction will likely affect fluid balance and electrolyte handling. Given his history of CKD, there is a concern that this patient may not be able to excrete excess potassium effectively. Thus, potassium should be monitored very carefully in this patient, and replacement should be guided by renal functions. Fluid therapy should be started cautiously. Overhydration can lead to pulmonary edema in case of diabetic with CKD or further renal impairment. So fluid resuscitation, it should be titrated based on patient's clinical condition, output, and vital signs. Now, what complications should arise in this patient and how would you manage them? Probable or possible complications like cerebral edema, as we had already discussed, if there is too rapid of a reduction in blood glucose or overcorrection of fluid balance, arrhythmias due to electrolyte disturbances because he is a case of CKD, particularly potassium, AKI, given the patient's underlying CKD, careful monitoring of renal function and fluid status is very critical. How can you manage these complications? Start fluid therapy at a slower rate, monitor renal functions closely, monitor ECG, vital signs, urine output. If renal functions further deteriorates, consider nephrology opinion for further guidance in managing of this AKI and electrolyte disturbance. Gradual reduction of glucose levels to avoid rapid shifts. Now, when should you consider transferring to a higher level of care? This is very important. You are doing your work very with a pure soul, kind heart, but you always, back of the mind, have some points in your mind when you have to shift this patient to a higher center. So transfer to an ICU should be considered if the patient exhibits persistent hypotension despite adequate fluid resuscitation, worsening of the renal function, persistent oliguria, severe electrolyte disturbances that cannot be corrected, signs of cerebral edema, or any indication that the patient is deteriorating despite appropriate and best management. So after the talk about management of DKA, to summarize and key takeaways, which are very, very important and easy to learn. Fluid management, step-by-step approach, starting with aggressive resuscitation, followed by careful monitoring and gradual rehydration. Number one, electrolyte balance, close attention to potassium, very important, and corrected sodium levels. During management, insulin therapy, correcting hyperglycemia is the key and the main cornerstone of the management, and ketosis simultaneously with a careful adjustment to avoid hypoglycemia and complications. Thank you so much for the patient listening. I had tried my level best to make DKA looks easy and manage easy. Thank you so much. I'm open to all about any kind of questions. We have some questions in the chat box. I'll try to summarize them first. Can we give a question by Dr. Sai Teja? Can we give bicarb and potassium in same NS bottle, sir? Yes, you can give, but be very cautious. If you are giving potassium, rate should be very carefully monitored because we cannot give potassium rapidly. So I had again and again asked, bicarb is not a cornerstone and main important point of management of DK. If yes, pH is less than 7, number one. Bicarbs are very low, potassium is very low, hypokalemia. Yes, you can infuse NS 400 ml, 100 ml of bicarbs, only 20 to 30 milliequivalents of kesol in that particular drip. But rate of infusion you should always keep in mind because we again and again are talking about rapid infusion. But in case of any drip having kesol in it, rate should be monitored, ECG should be monitored. One more question by Dr. B. Darshan Koyal. What in case if patient has uncontrolled sugars, ketone positive, but no acidosis? Yes, this is uncontrolled hyperglycemia, but you have to keep back in your mind possible condition of DKA because if it is he or she is having uncontrolled sugars like 500, 600, ketones are positive, he or she can land up in DKA anytime. So you have to aggressively manage this patient because if there is acidosis, you have to add insulin. Otherwise, insulin you are already giving. So always consider this kind of emergency as a DK. Whether he or she does not land up in DK, but uncontrolled sugars with ketosis, always start with fluid for first hour, then give insulin. Next question by Dr. Sai Teja. Role of RL as a replacement fluid in DK, especially for children, sir. See, always try to prefer NF, but in case corrected sodium is high, sodium concentration is more than 152, we can switch to N by 2, N by 3, 3, 4. always try to give NS because we have to look for potassium simultaneously again and again. RL you can use, but preferable fluid is always NS. Can KCl give in other fluid than NS fluid? Yes, you can give, but we are talking about DKA. So cornerstone of our fluid management is NS. That's why we are talking about adding KSOL and NS. DKA patient in severe acidosis with sudden cardiac arrest. Can we give bicarb bolus while doing CPR? Definitely, because life saving is the first and most important duty of all our doctors. So if a patient is in cardiac arrest, but you have to look for potassiums because he or she might lined up in cardiac dysarrhythmia or arrhythmias due to hyperkalemia. So in that case, bicarbonate can be detrimental. So you have to be very vigilant. So always trust on your ABG because ABG you can do in 3 or 4 minutes. ECG you can give in 2 minutes. But yes, if a patient is on dead bed, you are doing CPR, you can give. Management in CAD and CKD patient with DKA, how fluid management has to be done? Dr. Koyal, I had already discussed CKD beta in case 4 thoroughly. Simple 3 points you have to, don't fall, sprain, any kind of complication. 3 points. Patient's hemodynamic status, urine output, and electrolytes. Just check BP every 13, 14, 15 minutes. Check potassium every 2 hours. Check urea creatinine every 2 hours. Check urine output every hour. These 4 points always tell you what can be the rate of IV infusion. Never hesitate to give fluid if he or she is a patient of CAD or CKD because our most important role is to manage DKA without compromising lung function, renal function. So check for any sign of pulmonary edema, check for any sign of overhydration. So always be vigilant with these 3 points. So will we use capillary refill time as a means to look for hydration while yes, definitely. See, normal capillary time is less than equal to 1.5 to 2 seconds. So always check for skin turgor, capillary refill time, but always have the back in mind, fluid loss kitna hua, how much the fluid, because in an adult, we used to calculate on that basis, but this is the best sign clinically at the bedside in emergency setting. Yes, definitely you can do that. Next, parallel treatment of precipitating factor can be, yes, definitely. We had a slide on etiology of DKA. Infections are the cornerstone. Definitely we have to give antibiotics, but there must be a strong evidence of any sepsis, infection, past fever history. Definitely we have to start broad spectrum antibiotics without fail, because if you are suspecting any sepsis, you have to go for cultures, but don't forget golden hour concept. Always infuse, always give broad spectrum antibiotics without any doubt if there is an precipitating factor of infection in DKA patient. How to do capillary refill time correctly, sir? See, capillary refill time, you are at the bedside, you are measuring blood pressure, you are checking urine output, just hold his or her finger, check the capillary refill time. In how many times you can check the thready pulse, you can check how blood is infusing towards the periphery, because this is the simplest time if blood is refilling or not. If I'm can we switch to subcutaneous insulin on basis of ABG or urine culture? No, never. Simple basis to switch to subcutaneous insulin. If your patient is able to drink and eat, sugars are controlled, ketones controlled, acidosis controlled. That means resolution of DKA, number 1. If a patient is still in DKA, never shift to subcutaneous, never in a rush to shift to subcutaneous. The patient should be vitally stable, hemodynamically stable, start to eat, start to have oral fluids. Only in that case, try to overlap to subcutaneous therapy. Will we increase the dose of insulin during infections for diabetics to prevent DKA? No, never. See, infection is a catabolic state. Insulin is an anabolic hormone. You have to very vigilant about the monitoring SMBG or CGMS or what your patient would love to monitor. Because in case of type 1 diabetics, very important if he or she is having infections, you have to be very vigilant about the blood sugars level, because infection is a catabolic state. It will hamper your control of sugars. So you have to make your patient understand you have to monitor sugars for at least 6 or 7 times. Accordingly, you have to infuse your insulins, because we on any type 1 diabetic, he or she should be on basal bolus, never give premix. So in basal bolus, you can easily titrate on the basis of blood glucose levels. Never blindly increase insulin dose. Never, never. Kindly let me know if any query, question, or I'm still open to all. Yeah, can we stop insulin in DK if it resolves within 1 day? Yes, see, there is no time duration. Only duration is of resolution of DK. Definitely you can stop. But the thing is, in whom patients you are stopping the insulin. If a patient is type 1 diabetic, you have to give insulin. Yes, you can shift to subcutaneous or shift to his or her basic regime, basal bolus regime. Yes, definitely. There is no time bound duration. But if a patient is of moderate to severe dehydration DK, you have to give for a fluid resuscitation for 24 to 48 hours. You have to monitor sugars for 24 to 48 hours. So in case of moderate to severe dehydration or moderate to severe DKA, you cannot switch to subcutaneous insulin or stop insulin. You have to wait and watch his or her clinical condition, hemodynamic status for 24 to 48 hours.
Sir, two questions in chat box, sir. Sir, two questions in chat box, sir.